everyone. Thanks for joining tonight. This is Knee Pain Explained for runners and cyclists. My name is Courtney Jacobson. I'm one of the founders of GritLink. And for those of you who are not familiar with GritLink, we connect endurance athletes with healthcare providers who are specialists in working with athletes. So the topic tonight is, as I said, it is Knee Pain Explained. And we did an event a few weeks ago for runners all about run form and learning to assess your run form for injury prevention. And 64% of the runners on that webinar said that they experience knee pain. So we know it's a common issue that runners have. And also for cyclists, it's, you know, our knee is a strange joint that bears a lot of the brunt of our activity. And resolving the issues can sometimes be a mystery. So we have a special guest here tonight, Robb Lamb. Robb is an ACL expert. Robb is also one of the strength coaches in the GritLink Provider Network. So our goals tonight for you are to educate you about knee anatomy and injury prevention. And then Robb is also going to talk about knee pain so that you know when you're experiencing pain, what that pain might be signaling. A little more about Robb. Robb has a Master's of Science in Sports Administration. He is a certified athletic trainer and a certified strength and conditioning specialist. He worked as an athletic trainer at the collegiate level for 6 years before opening his personal training business, Rehab to Sport. He also works at Tangelo Manual Therapy and Movement in West Seattle. You can see he's there right now, the sign behind him, and he is a rehab specialist for Tangelo. Robb became interested in ACL rehab because of the high recurrence rates of re-tears and the seemingly long-term effect this has on athletes and patients. So he started a ACL bridge program to bridge the gap between classic rehab and the holistic process of fully recovering after ACL injury or surgery. So thank you so much, Robb, for being here tonight and sharing your knowledge with us. I'll turn it over to you now, Robb. And you do look good and you sound good.
Let's keep it going that way. Thanks a lot. Thanks for doing the questions. All right. We will get this going then. All right. So we're going to start rolling through these. If there's something that doesn't get answered throughout this presentation, and we don't have time at the end, feel free just to contact me. My email address is up here. Feel free to direct message me on my my Instagram account. I'd love to be a resource for anybody out there who doesn't feel like we quite got to what they wanted to get out of tonight. So moving on. We're just going to talk about 3 common knee injuries for endurance athletes. So of the 3, I'm just going to mention patellar tendinopathy, not tendinitis. We'll kind of get into that. IT band syndrome or IT band pain. I'm sure a lot of you have either dealt with that or heard of that. And then patellofemoral pain syndrome. And I want to get this across too. These are all training injuries, meaning you're doing too much of something too soon, and that's how we have to hopefully adjust or affect your training. So there are 2 slides I want to go through here before we get into just talking about the 3 knee pain or the 3 knee issues that we mentioned. So I want to get across, so talking about the gold standard for rehab. So when we're looking at this pyramid here, I'm really excited I get to use this laser pointer. So this is just decades of really high quality research on what these things and how they affect pain and how they affect tissue recovery when we're talking about knee pain. So down here at the bottom, the big base of the pyramid, we've got exercise. So that is the most important one. And we're going to skip over some of these other ones. But I think there's a lot of misinformation about kind of relying on manual therapy to help with recovery. And so we're going to talk a little bit about manual therapy and exercise. And the point I want to get across with this is I just don't want people to feel like they need to be reliant on manual therapy here. And when I'm talking about manual therapy, we're talking about foam rolling or self-myofascial release, all those fancy tools that they sell now. We're talking about Graston. We're talking about massage or myofascial release. They're the same thing. Active release technique, ASTEM, which you're just using those tools like instrument assisted soft tissue stuff. So what do these actually do? With this stuff, you are absolutely not breaking up adhesions or breaking up scar tissue, and you are not increasing or decreasing the time it's going to take for your injury to heal. But they do help. You know, exercise and manual therapy together can be a strong combination if they're used correctly. But what do these do? So most likely, if you're foam rolling, if you're getting massage, these just temporarily desensitize the area, or they affect how the brain perceives pain. So the big point I want to get across here is use these if you want. Just do not make manual therapy the basis of your pyramid when we're talking about recovery and rehab from knee injuries. And then the second point I want to make before we get into the 3 knee injuries that we're talking about, how do injuries happen? And we're not talking about, you know, you went and stepped in a hole and rolled your ankle or tore something. We're talking about how do training injuries happen. A lot of people get confused about, you know, I'm not quite sure what happened or how this knee pain came along. So we're going to talk a little bit about people's envelope of function later. So I just wanted to kind of go through this right now. This is just a visual of what too much too soon might mean for somebody. So if we look here on the left, this is just a random endurance athlete, let's say. So this is their manageable threshold right here, down here at the bottom. So this is things that they can do without causing injury or without causing knee pain. So something like a high load task, like jumping from 2 meters or 7 feet or whatever that is. They're able to do this and probably not cause themselves harm. This is high load. They're not doing it very frequent, so that's why it's up here. And then if we go down here, guess what else they're able to do? They're able to run for an hour. That's great. You know, not a high load activity, but very high frequency. And then we get into this kind of excessive zone here. And so running an hour and a half, that may just have been a little bit too much into that excessive zone. So that's something that could cause an injury for this person. And then running hills for 30 minutes, jumping from a 9-foot box. So things like that are just a little bit out of their zone of whatever their manageable threshold is. And then the big point I want to get across tonight is what happens after injury. And this might just be a week after injury. This doesn't mean that you're losing muscle mass, you're losing strength, but your tissue is just not tolerating what it used to. So all of a sudden your manageable threshold is way down here. But the big important part that we want to get if we have somebody in the clinic with patellofemoral pain or IT band pain and they're a runner or a cyclist, we want to keep this little manageable threshold as high as we can. Because if you're just resting and icing for 2 weeks, this is going to shrink, and then it's a much larger hole to crawl out of to be able to build up the tolerance to these activities like running for an hour or jumping off of this 2-meter box. So it's just a larger hole, and it's going to take a little bit more time. So those are the 3 big takeaways just from this graph right here. So moving on. The first one I want to go through is patellar tendinopathy. We're not going to spend a lot of time on this one for 2 reasons. One, it tends to be the least common of the 3 if we're just talking about runners and cyclists. And then also it's kind of its own bear. It's its own rabbit hole to go down. So I just didn't feel like we had time to quite go into this. But I did want to make a couple of points here. Tendinopathy is kind of the preferred term that we use now instead of itis. Itis meaning that there's inflammation in something. A lot of times if you have like plantar fasciopathy or Achilles tendinopathy, there may not be inflammation in these areas. And what we used to think, and now research has kind of come out showing that it's probably not the case. Pain is just caused from overloading that tendon. What does that mean? That means that icing and stretching is probably not your best bet if you have something like a tendinopathy here. And again, I don't want to go into this slide too much. We can always kind of go back, or if you guys have questions about this, then we can go back through this. But I did want to make sure and put a good resource if there's anybody out here that's much more interested. So down here, there's just a really great blog piece of someone who wrote, one I know who wrote a nice blog piece about runners and patellar tendinopathy down here. So like I said, we can come back if we need to, but I'd rather make sure that we have time to talk about the other two.
And just a note, just sorry to interrupt, Rob, but just a
Yeah.
quick note that I will make sure that all of you get these links that Rob is referring to, and also a copy of this presentation as well.
Thank you. Okay, IT band syndrome. What is it? Your IT band, which I'm sure a lot of you are, know whether you've had problems with it or not. Really thick piece of tissue that comes all the way down from that lateral side of the hip, connects into a lot of different tissue all the way down and in the lateral side of your knee. Your IT band is really important. It's responsible for absorbing and producing a lot of load, especially with runners and cyclists. Who is at risk in the running and cycling population? We'll get to that a little bit later. One thing I know people hear quite often if you've been in a clinic before is that you've got IT band friction syndrome. Friction is kind of a scary thing to hear if you're thinking about, man, I've got this large piece of tissue that's just rubbing against this piece of bone down here where people mostly get pain. That's probably not the case. A lot of times what we see now is it's more of a compression issue, meaning you've done something that knee is just not handling, and maybe now that's compressing against that side of your knee a little bit. And I'll talk about why that's important later. A lot of weird things that get talked about with the IT band. Does this thing stretch? Can we affect it with our hands with a foam roller? The answer is absolutely not. So to create a 1% change in the tissue, meaning you're stretching it, you're moving it, it takes about 9,000 newtons or about 2,000 pounds. So you need a car or a truck to drive down your IT band if you want to break anything up in that. So next time your massage therapist is telling you that they are releasing adhesion through your IT band, that's probably not the case. We always get questions on foam rolling. Is it safe to foam roll? Should I not? It's kind of a mixed bag. If you don't have IT band pain, your knee's not flared up, and you really feel like foam rolling your IT band because you are a sucker for pain and you enjoy that, then that's fine. But if it is truly IT band syndrome, like we said, this is a compression thing. So adding more compression to that's probably going to irritate it a little bit. And that's not dangerous. It's just, you're probably not going to get much out of it. It's just wasted time. The most important question, what protects against IT band syndrome? So we'll talk about that when we talk about a good rehab program and good training measures at the end. Okay, IT band syndrome. Most of the time, this gets blamed on valgus position for the knee, where that knee tends to collapse inward, which is fine and all, but there are a lot of runners and a lot of athletes who get away with this. So we cannot say in the clinic, we cannot predict who is going to have IT band pain. So one thing that we do look for if we are doing some sort of running analysis, we look for a normal knee window versus a closed knee window. So right here, if you see picture A, this is kind of what a normal knee window looks like. We want to be able to see through that little gap in between the medial portion of the knee right there. And then B, over here, we have not a normal or a closed knee window, which means that this angle of their hip is a little bit increased and there might be a little bit more strain or stress through that IT band. But guess what? If this person came to the clinic and I saw them run, I would never say, you know what, you're going to have IT band pain, because there are a lot of people out there who have the strength and capacity and tolerance to be able to run with this position. So it's not always predictive of IT band pain. One thing here, the goal is not to fix this movement pattern. As much as we'd like to think that we can as healthcare professionals or strength coaches, fixing these patterns is really difficult. We're not just going to give you clamshells and all these lateral hip movements and expect for you to get back onto the treadmill and for these things to change. So if fixing this movement pattern is not the goal here, then what do we want to do? We want to increase the tolerance of all the tissue around it. We want to make sure that you're strong enough to be able to run a little bit closer to this. Big point here is that we can't always predict who is going to have IT band pain. It always gets blamed on a weak glute or weak hip That just doesn't always hold up in the research. That's kind of relative to whatever task you want to be able to complete. So, but what we do know is that, so research doesn't show that hip or glute weakness causes IT band syndrome, only that if you do have IT band syndrome, meaning you've been diagnosed with that from a healthcare provider, then it will cause your hip to present as weak. So you're going to come in and it might seem like your hip is weak, but that's probably just because of the pain. The more important information that we want to get if you do come to the clinic with this is what led to this point. What have you been doing for the last week? Or what has your training been looking like for the last month? This is a lot more valuable than watching somebody squat at the moment when they're in pain. And then one thing I want to get across is that knee valgus is not always inherently bad. Sometimes, so that's why I have these pictures over here, sometimes it's just a strategy to get out of a certain movement. So we've got an Olympic weightlifter over here moving some really heavy loads. His anatomy is probably just so he's able to get in and out of this position. Now, if he were to do 100 of these throughout the week, then that might be a different story. His knee might not tolerate that very well. Some others that always get blamed with the running population here too is overpronating through the foot, which we don't really have a good definition of what overpronating really is. And then you see, so this is a very high level marathon runner here. Her name, God, I'm gonna butcher her name, Priska Jeptu, I think. She's a Kenyan marathoner. And she's just somebody who presents with a large amount of knee valgus, but that's, she's so high level, that's not something that we would want to change, and she's able to get away with that. So the point here being that extreme points of valgus can cause this, but that's not always the case. And valgus happens for different reasons other than just a weak glute. So moving on to some of our rehab goals. And why. And this is just to get a window into what a rehab program may look like if you do have IT band pain. We don't ever want you to come out of a first visit feeling confused or feeling like you have more things wrong with you than you did when you came into the visit. So, and the big part of this I want to talk about is this kind of feedback loop here. And I think this helps out a lot of people when they don't understand, should I progress? Should I do a harder exercise? Should I regress? Should I do an easier exercise? Step one, we want you to reduce or cease your painful activity. If you're running and you're able to still run a little bit, if you're cycling and you're able to still cycle a little bit without further irritating those, and remember that's probably not inflammation, then we want you to be able to do that. We want you to be able to keep your threshold high so you're not climbing out of that big hole we talked about at the beginning. We will start you on some sort of a hip strengthening program. This is not because you have a weak glute or weak hip. This is just because we want to start loading the tissue around the knee to help desensitize it to pain without making you bend your knee too much. So making sure that we find really hard exercises for you that aren't irritating your knee. And then we always want to make sure that we get into some heavier, slower resistance training. And this is when I want to talk about this feedback loop right here. So this is when your rehab program should really start to look like the activities that you want to get back to. So there's no cookie cutter rehab programs for this. And we get these questions a lot when people aren't seeing us as often, but they're still kind of in the middle of their program. How do I know if what I'm doing is too much or too little? I'm not going to go through this whole feedback loop here since you guys will have this afterward. But it just gives you an idea, and I did not make this up. I'm not that smart, but this is Scott Wilson. He's a PT down in Portland, I think. So he's a good follow on Instagram if you want to do that. So, and just to give you an idea, so, we're talking about if we picked an exercise, let's say we're making you do a split squat. So during the exercise, are your symptoms over your threshold? Meaning, is that acceptable pain or unacceptable pain for you? So let's say that it is. Is this a new exercise? Yes, it is. So then we kind of follow this feedback loop down here. And again, I think you guys can all kind of follow this, but it's a really good baseline to be able to tell if what you're doing is too much or too little, because we want to make sure they're loading you enough to make sure that you can truly get to that activity that you want to. And our goal is always to be more robust or more tolerant or more, or just stronger than when you came in, so you don't get back to that point. So moving on, this is what we don't want out of a rehab program. I'm going to talk about this a little bit, and this happens, far too often, where people get confused as to, I had IT band pain. I'm completing the exercises my therapist or coach or chiropractor has given me, and then I get back. My pain decreases, and I get back to running, and it's just kind of this cycle. So we really don't want you to get into this kind of rehab purgatory phase, which is this picture over here where, all right, you've got an IT band injury. You did a little bit too much. All of a sudden, hey, you stopped loading it. You're doing your hip exercises. Oh, wow. Whoops. Sorry, guys. And you offload it. So that means you rested it, but you're also losing capacity, meaning your threshold over here is starting to drop more and more. And yes, you are going to have a decrease in pain because you're not doing anything. We don't always want that decrease in pain to be the primary goal here. We want you to get back to running or back to cycling or whatever that activity is too quickly, or just end up in this kind of reciprocal relationship over here. So that's why at the beginning we talked about how important it is when you do have one of these issues, whether it's IT band or patellofemoral pain syndrome, that you're continuing to do as much as you can, because it's not dangerous for that knee. We just want to make sure that the threshold is still as high as possible. So the next slide is just kind of a template of what a rehab program could look like. And these are all video links over here. We're not going to play them just because of time, but like Courtney said, everybody's going to have this at the end. So you guys are welcome to sift through these and give yourselves some ideas. And these are just simple exercises. But the big one I talk about is get closer to the end here. And this will make a little more sense when we talk about training areas at the end. So these videos all kind of move. They start with more hip dominant, and that just means that your low hip and your glutes a little bit more. So we're irritating that knee, irritating that IT band pain. And as we move down, we want to make sure you really start to load that IT band and load the structures around the knee. So we're getting into more knee dominant exercises. Especially if you're a runner. If you're a cycler, you're probably starting to do some sitting here and really build up some mileage again, build up volume on some flat ride, things like that. And then if you're a runner, running is a plyometric exercise. So we want to make sure that we are, we're making sure that that IT band has been through some plyo work, because if that's about, I think, anywhere from 4 to 8 times your body weight as far as force goes into your knee. So what we like to do is you might start off with some gentle skipping. You might start off with some hops, side to side, some skater hops, just so you can get that knee used to absorbing load in. And then this is the fun part. This is when we really start to kick mileage back up. We want you to slowly start.
Rob, I don't know if you can hear me, but we lost you.
We talked a little bit earlier about not being able to change running mechanics easily with exercise. So
Rob, we just lost you there for a little bit.
Oh, okay.
But like about 15 seconds or so.
Okay. So when we're talking about running, running is a plyometric activity, and we want to make sure that this is the fun part. This is when we start to expose your knee to some plyometric activities that are a little less stressful than running, like gentle skipping, A skips, B skips, working on some skater hops, things like that. And then that's when we start to build that mileage back up. But if we're doing that, we have to make sure to take something else out. So that's when we really start to take out plyometric exercise, overloading your knee. And then the fun part here, so we talked about how hard it is to change mechanics when you're running with exercise. Maybe the case, but what we can do is we can work on some skills at the end to offload your knee a little bit here. So I think that most of you guys are probably familiar with what cadence means. So just the foot strikes per minute, which is also how many spins per minute if it's cycling. So if you look at this picture here, and this is something that we'd actually probably do at the very beginning too, if knee pain is not too bad. Picture right here, this person had come into the clinic with some IT band pain, some lateral knee pain. And so they measured their cadence. And then picture right here is actually the same day, but all this person did was increase their cadence by about 7.5%. So you can see here that she was running at about 174 steps per minute. So as you see, that changes her mechanics a bit. So it's just enough that she's got that normal knee window that we talked about at the very beginning. And so she's starting to offload her T-band pain a little bit here. So we don't want to get too far into the weeds as far as like mechanics and running, but there are really simple ways to adopt different foot strikes, so decrease the amount of load on that knee. And we'll talk about this at the very end of the slides, but there's a lot of research and work on this, but anywhere from kind of a 5 to 10% increase in your cadence is enough to decrease the load on your knee. But it's not too much to where your heart rate will be at a zone that you're probably used to. And then a little bit more specifics for cycling on the last slides. So this is the fun part, you know, that we can change these things, and something that we do want to look at is cadence for knee pain here. All right, so patellofemoral pain. So what is it? So your patellofemoral joint, kind of a, it's a big general term here. So where your femur connects to your tibia, and basically if you have patellofemoral pain syndrome, that probably means that everything else has been ruled out. You've got pain in the front of your knee, and it's usually pretty persistent. So who is at risk? It's kind of like IT band pain. We don't truly know who is at risk for pain, for patellofemoral pain syndrome. And I hate the word syndrome. It makes it sound like a disease when it's not. But the only thing that we can say who's at risk is there's some really just minimal evidence to say that a weak quad could lead to this, which is kind of a weird thing to say because you need different types of quad strength for different activities. But signs and symptoms of this, a lot of people, one of the more popular ones is, you know, I sit for too long, I get up, and then it's just really sharp knee pain or really dull, achy knee pain that won't go away. That's the big one. Usually it's pretty tender around the front of the knee. Usually not a lot of intense swelling with this. That might mean that there's something else going on. We'll go into kind of like just myths surrounding this movement a little bit later. Sorry, myths surrounding this this injury. And then same idea. Don't worry about asymmetry. We'll get into that a little bit later. But I really like this picture down here. And honestly, I just couldn't find another place to put it, but I thought this was pretty accurate. This is kind of what people expect from the rehab process when we're talking about staying active in knee pain. And this is usually what happens. There's a lot of trial and error here, so we'll get to that a little bit later. Okay, so.
Rob, we have a question in the chat related to what you're talking about. Is it common for cyclists to have knee pain caused by a bad bike fit or cleat position on shoe?
Yes, and I will be the first to admit that I am not an expert on bike fitting. And I've actually got a nice blog for that at the end because I felt like I wasn't doing justice if I didn't give some more information on that. But yes, that is. So a lot of times it could be where your ankle position is. So it might be putting a little more torque onto your knee with pedaling. Or it could be a cadence fit too, and we'll kind of talk about that later. So verified. So this is just kind of separating some myth from some fact here. So we'll go through verified causes first. This is what we do know, which is actually not a lot. We talked about there's some evidence that like maybe your quad is lacking a little bit of strength side to side, and that might cause you to present with some patellofemoral pain if your activities are high enough. Loading outside of somebody's envelope of function, what we talked about in one of the first two slides. a history of patellofemoral pain. So if you've had it for a long time, you are more likely to get it again. That does not mean that you are broken at all. It's just something that we've got to find to really have a patient and really holistic rehab plan for. And then some evidence for some of those more extreme cases of knee valgus that we talked about, but even that is hard to say. This is just causes that I used to hear, and when I first started out, I probably agreed with because that's what I was taught. But these don't have much merit at all to these. So you hear a lot more in the fitness industry now, but talking about how bad positions like your knee being over your toe, that is absolutely not a bad position for your knee. Your knee is not going to explode. That's something that we need to do on a daily basis. If you're running downhill, if you're going downstairs, if you're squatting with heavy weight, it's just something that maybe you haven't built up enough tolerance for. So it's not bad inherently. I love the knee extension machine. I know it got a bad rap for a while because of some really crappy studies for ACL, but what we started to find out in research is that you're actually putting more stress on your ACL if you're squatting with 30% of your body weight, or if you're just walking downstairs. So the knee extension machine is not bad for your knee. It's actually something that can be really important for patellofemoral pain syndrome patients. I hate hearing this one, but again, I've probably been guilty of this when I first started out. Your knee hurts because your hips are out of alignment, which if somebody tells you that, they're probably talking about your SI joint in the back. If we're looking at somebody laying on a table or moving and looking at all these landmarks on your body, it is way too hard to tell with just your eyes. That on top of the fact that if we're talking about your SI joint in the back moving, that's been shown to move about 0.3 of a millimeter. So it's a null point. We don't need to worry too much about hip alignment. This is a big one too for a while. Your knee hurts because your patella or your kneecap just isn't tracking properly. That's a whole other, like we talked about, kind of just a rabbit hole to go down. But again, that's probably not the case unless you've had a really bad patellar tendon tear or a dislocation and you've got some really serious old injury. All right, you can just throw this out the window. This needs to die. And then the last one, your knee hurts because you have a leg length.
Rob, I'm not sure if you can, oh, we lost you again.
Oh, can you hear me now? Sorry about that.
Yes.
So last one here, your knee hurts because you have a leg length issue. Most of us are probably walking around with some sort of leg length issue, but we've probably adapted to it over time, and that shouldn't be the cause of your pain or the issue. That you need an x-ray to see this. We can't see laying on a table if you truly have a leg length issue. So that's another thing to kind of throw out. So moving on, I want to go through a little bit of just a rehab template and why, and it's pretty similar to IT band pain and the idea here. So we won't spend as much time on it. So same idea. And again, these are video links here for you if this is something that you guys are interested in watching. But just some ideas. So we want to make sure that you're moving and loading structures right away. So we're talking about hip dominant exercises, and that's just so we don't, piss that knee off worse than it already is. But again, we need to slowly start to move down the chain and really start to load that knee and load that patellofemoral joint and your quad and everything around it if we really want to get you out of this cycle. So it's the same idea. These exercises are kind of in descending order here, where they're starting to get a little more load on the knee when we get down to here. And this is where I'd actually start, probably if we had a knee extension machine, doing some stuff like that, getting some high loads onto that patellofemoral joint. But again, I just wanted to have you guys to have a window into what a rehab program might look like. And this is not the end all be all. These exercises up here, they need to be molded to the person. So if we've got somebody who's a power lifter and they're really strong, probably not going to be having them do a lot of single leg bridges and stuff like this. This stuff up here might be more of like we're just doing deadlifts for a while until your knee calms down, and then we can start moving back into more knee dominant exercises here. But again, just a window so you guys can kind of see into what a template might look like here. So before we get into, I think the big meat and potatoes of this is, we talked about why do these injuries happen. So like I said, 60 to 70% of these injuries for runners and cyclists can be traced back to just training errors. So just doing too much of something a little bit too soon. So if we're talking about this pyramid here, being able to manage your own loads throughout the week and throughout the month, this stuff is way more important than perfect form or flexibility or anything like that. I'm not sure what quackery is. I think it's a really angry British guy who made up this pyramid. So, and again, this is not perfect, but I would be weary of people saying injury prevention programs. We cannot prevent injuries. We can reduce the likelihood, but the big meat and potatoes here is being able to control your own loads and your own training programs throughout the week and month to avoid these things. So let's go into that. I know a lot of you guys were interested in that at the very beginning. So, all right, so the first one, just doing too much too soon. This is kind of the hangover of training, right? You're doing too much too quickly, and you feel better all of a sudden, and you're right back at it again. And there are 3 elements to training. So we've got volume. Let's say that's how many total miles you're cycling or running per week. We've got frequency, so how frequently you're doing something like that, or how long some of these workouts are. And then intensity, so some higher intensity training like strength training or intervals, things like that. The big thing here, if you don't take away anything else from tonight, is that if you have a training program through the week or through the month, it's important that you only change one of these elements at a time. If you're increasing your volume, you should not be increasing your frequency or your intensity, and then vice versa with these two as well. The 10% rule is something that gets talked about with runners quite a bit, and that's just the 10% of total volume a week. This is a great rule of thumb. So if you're running 30 miles a week and you want to know how much you should up that volume for the next week, this is just a general rule of thumb. This is not for everybody. If you're on the lower end of that spectrum, that's probably not quite enough for you. If you're on the higher end of that spectrum, if you're somebody putting in 100 miles a week, probably don't want to increase that by 10%. So just something to think about. And some just tolerate change better than others. If you've been training for a long time, 10, 15 years, you've built up this high chronic workload, that can be pretty protective, and you might be able to get away with a little bit more than others. So moving on, number 2. Number 2 is just too much high intensity work. So again, this is just a window, or this is just something to think about when you're looking at your training program. So especially with endurance athletes, you should be aiming, and this is not me telling you this, this is just decades and decades of research on endurance athletes, maybe 1 to 2 high intensity days per week. There are a lot of benefits from low intensity days. So if you're looking at the makeup of your training program, whether that's per week or per month, about 80% of that should be low intensity endurance based work. So if we're going to talk about high intensity work, I want to give you some examples. That might be like your tempo sessions, your steady state runs, interval sessions, hill workouts, heavy strength training sessions, so on. And that kind of brings us to number 3. So number 3 would be poor weekly planning. And this is something, if you're paying a strength coach or an online coach, you have every right to ask them why they're programming something for you. Don't assume that needs to be the way. There's a lot of change that you should have a say in this. So you always think about how one session may interact with the other. So I think this is a lot more valuable. So if somebody comes into the clinic with knee pain, this is much more valuable information than taking them through some FMS screen or something like that. Not that you can't get information from that, but we're missing the boat here if we don't ask them about what they're doing for their weekly plan. So this is just a patient example that we had a while ago. So Monday, this person was doing a pretty heavy strength training session, a lot of good stuff in there. Tuesday, this was their long run, so longest of the week. So they're starting to run on tired legs here. Wednesday, the tough, probably the highest intensity workout that they had. They were doing intervals. So that's the pretty heavy duty days. And then Thursday, no problem with CrossFit. They enjoy CrossFit. It's kind of a social thing for them. But again, pretty high intensity interval training. And then again, followed by a strength train. And then again, Saturday, then they started doing a tempo run. And Sunday was a spin session. And I think they said they drank all day and watched football. So not a true recovery day there. So this is just an improved example of what I did for this person. And this is not perfect. This is just something that we wanted to fit with their goals. I don't want to take away things that they enjoy. So we just added a recovery day. That was the big thing. And that may not mean full rest. That may just mean something that's really low intensity, low volume. And then we put the long run in, and I'm not going to spend a bunch of time on this, but it's just something to think about. I encourage all of you, if you train consistently, to have some sort of journal so you can always go back and build up some clues as to why you may be getting like nagging knee pain. Number 4, just rapid return from break or injury, or quarantine in this case. So it's not always exciting, but you've got to kind of earn the right, like build up that chronic workload again. I like to think about it as if you get injured, or let's say you're on holiday break and you haven't done anything for a month, you kind of emptied out your savings account for training here. You broke the piggy bank, so you need to build that savings account back up if you're getting back to those activities that you used to be comfortable with. Number 5, individualized training. We're all humans. We like to socialize. We like to work out with other people. Some of us do. But just remember, this is just something to think about. I'm not trying to take you out of training with your friends, but you may not be on the same level, and there's a lot of things that affect your training stimulus, whether it be sleep or stressors or nutrition or your job or your schedule, things like that. Just don't end up like me. This is kind of what I do every time I try to snowboard and follow people down the mountain. It leads to some serious injuries here. So number 6, so the last, the most common training errors is just no planned recovery weeks or inadequate recovery. So I try to encourage people, if they have a plan that's longer than a month, that every 4 to 5 weeks, if you're an endurance athlete, and this is kind of dependent on how you feel, you should plan some sort of recovery week. And recovery week doesn't mean rest. That just means start to decrease your total volume by 10 to 30%, depending on the person. The fun thing about this is that you get to maintain some of your higher intensity workouts. So your performance is not going to have long enough to start to decrease here. And I know that this is relative for anyone, but that might mean that, like we said, that might mean for some of you, you're keeping some of your heavier lifts, you're keeping some of your plyometric work, you're keeping some of your tempo runs or your hill sprints, things like that. And just an example to get an idea, a lot of times with sports teams, and I work a lot with high school basketball teams, if they're in season, they're doing a lot of work throughout the week. We continue to lift really heavy a couple days a week, but the volume is just much lower here. So they're maintaining their strength toward the end of the season, but then we decrease their volume a little bit. So that was the last of the training areas. And the last 2 slides, this is just specific tips for runners. If you are a runner with knee pain, but it's not too much, you feel like you're going to be okay, just some tips for you. So again, try not to do too much too soon, getting back from break. Start with flat runs and work on building up volume first, not necessarily intensity. We talked about cadence. There's a lot of ways to measure your cadence. A lot of the GPS watches have it. There's some really good apps out there, free apps like Run Cadence. And just an increase in 5 to 10% can really start to reduce that stress on your knee. I remember when I started doing this, my heart rate was a little through the roof. So you got to get used to those first 5 to 10 minutes warming up like that, but then you start to adapt to it. I try not to give too many I don't want to give intensive cues when running. You should be thinking about a lot of things when you run. But one thing we try to tell people sometimes is just try to run with really soft feet. And all this is going to do is it's probably going to increase your turnover, meaning your cadence is going to be a little bit higher. You might move to more of like a mid or forefoot strike. But again, we just do that because it's something that you don't have to think too hard about. And then I would start to limit or at least get rid of, if it's that bad, running downhill. Again, that's not inherently bad. It's just a little bit more stress in the front of that knee. Keep lifting. And then again, there's nothing wrong with a free consultation over at Tangelo Health. So same thing for cyclists. I'll be the first to tell you that I'm not an expert on bike fitting or anything like that. So I actually, same idea, I included a little blog here that's a great read from a cycling group down in Portland of PTs. And this just kind of goes more in depth to what we're talking about here. So it's the same idea as running, but what we talked about is cadence for bikers too. So add a warm up and pedal soft. So something greater than 80 revolutions per minute if we're talking about spin. And again, that's probably going to increase your heart rate a little bit. You might not enjoy that the first 10 minutes, but it's a lot less torque on the knee. So just something to think about. And then the other point I wanted to make, if you're a cyclist and you're doing some strength training, start to expose your hips and your knees to large varieties of movement. So what you do in strength training doesn't always have to look like cycling. Your knees and your hips really like variety. So start building stuff up like that. And again, there's the blog here, if that's something you want to look at a little bit more in depth. And I think that is our last slide. So.
Awesome. Yeah, we actually, Rob, thank you for that. We have a couple questions. I think these are both from the same person, both from Lisa. Looks like she's a runner. Does mobility floss or kinesio tape help with rehab?
What was the first one? Mobility floss? I'm actually not sure what mobility floss is. Is that similar to rock tape or kinesio tape or something like that? Well, we'll talk about kinesio tape here. So there is nothing wrong with wearing it. It's probably not supporting any structures. There's a lot of promises that kinesio tape makes that probably aren't happening, but what it probably does is it's pulling on your skin. Your skin has pressure receptors or mechanoreceptors so that they can sense pain. So it is probably just desensitizing that pain. So if you need to use it, there's absolutely nothing wrong with that. I would just try not to get to the point where you're reliant on always wearing tape.
Cool. The second question, thoughts about running with some arthritis in the knee?
Oh man, I really like this question. There are a lot of different levels of arthritis. So running is not inherently bad for people with arthritis. It can be actually protective against pain. It's just kind of the same thing. It's like any other injury. You've got to make sure that you've done some requisite work to make sure that you're building up the tolerance and building up the strength that you need to be able to run, to be able to increase your mileage. But I think that's a great question, and we encourage anybody that we have who's active with arthritis to be able to stay active, because that's the best protectant that you're going to get from pain with arthritic knees.
Great. Another question. I have knee pain following squats every time. This is a chronic problem. Could this be form? I've tried multiple things to prevent it.
I would say I would never, especially if you enjoy squatting, I would not want to take that away from you. But if that's become kind of a cycle where it's always painful, and it's hard to say, there are a lot of different things that we could change about your squat maybe to decrease that amount of stress on your knee. That might be one of those cases where if that's your activity that you don't quite tolerate, we'd start to do more hip dominant things like deadlift. And so you're changing the angle of your knee and then slowly start to build back up tolerance to what you need as far as as far as making sure that your knee feels comfortable with squatting. But and that's a good question. It's hard to say without a little bit more information. So if that's something that you want to talk more about, I'd be happy to answer that over email or direct message.
Thank you, Rob, so much for your time and for sharing this information with us. Thank you, everybody who attended tonight. Have a great night.
Yeah, thank you guys.